Hello everyone, today we'll be discussing severe acute malnutrition. Severe acute malnutrition is defined as the presence of edema of both feet or severe wasting, which we call the weight for height or length of less than -3 standard deviations or the mid-upper arm circumference of less than 115 millimeters or 11.5 centimeters. So you can use any of the three parameters to make a diagnosis of severe acute malnutrition. So one is weight for height of less than -3 st, mid-upper arm circumference of less than 11.5 centimeters, or presence of edema of both feet. However, in the presence of edema of both feet, you need to rule out other medical causes. So initial assessment of severe acute malnutrition, you need to start by assessing for general danger signs or emergency signs and take a history concerning. So one, recent intake of food and fluids, usual diet before the current illness, breastfeeding, duration and frequency of diarrhea and vomiting if at all it was present, and type of diarrhea, was it watery or bloody. You need to ask about loss of appetite, family circumstances, basically the socioeconomic history. If there's a presence of cough for more than 2 weeks, any history of TB contact, any history of contact with a patient with measles, known or suspected HIV infection or exposure. On examination, you need to look for the following signs and symptoms. So for shock, is the patient lethargic or unconscious with cold hands? You check for the capillary refill time. Is it more than 3 seconds or a weak or low volume pulse, rapid pulse, and low blood pressure? You assess for signs of dehydration. Check for palmar pallor, bilateral pitting edema. Check for eye signs of vitamin A deficiency. So how are these signs going to present? You check for dry conjunctiva or cornea. Look for bitter spots, corneal ulceration, keratomalacia. Children with vitamin A deficiency are likely to be photophobic and they will keep their eyes closed. So in such cases, it's very important to examine the eyes very gently, that is to prevent corneal rupture. Localizing signs of infection should also be checked for, including ear and throat infections, skin infections, or pneumonia. Assess for signs of HIV infection, signs for the opportunistic infections that may have occurred. Then fever, check for the temperature. Is it above 37.5 degrees Celsius? Or check for hypothermia, which is defined as a rectal temperature of below 35.5 degrees Celsius. Check for mouth ulcers. Then assess for skin changes, which includes hyper or hyperpigmentation, desquamation, ulceration, which is spreading over the limbs, thighs, genitalia, groin, and behind the ears. Assess for exudative lesions that can resemble severe burns, often with secondary infection, including candida. Conduct an appetite test. So in here you check if the child has appetite by providing ready-to-use therapeutic food, which we commonly call RUTF. You conduct lab investigations, check for hemoglobin. So diagnosis, as we mentioned even earlier, was weight for length or height of less than -3 standard deviations, mid-upper arm circumference of less than 115 millimeters, edema of both feet, kwashiorkor with or without severe wasting. Management of severe acute malnutrition. So children who have an appetite, basically the ones that pass the appetite test and are clinically well, and alerts should be treated as outpatients for uncomplicated severe acute malnutrition. Children who have severe edema or a poor appetite, basically the ones that fail the appetite test, they are unable to finish the RUTF or present with one or more general danger signs or medical conditions requiring admission should be treated as inpatients. On admission, a child with complicated severe acute malnutrition should be separated from an infectious area and should be kept in a warm area, so whereby the temperature should be maintained between 25 to 30 degrees Celsius with no drought, or in a special nutrition unit if available, and patient should be constantly monitored. On the general management of severe acute malnutrition, so if you decided to keep a patient for inpatient care, for triage assessment of children with severe acute malnutrition and management of shock, when there is corneal ulceration, you give vitamin A, instill chloramphenicol or tetracycline and atropine drops into the eye. Cover the eye with a saline soaked eye pad and bandage. Severe anemia, if present, will require urgent treatment. So, general treatment of severe acute malnutrition involves 10 steps, which is in two phases. So, divided into initial stabilization phase and rehabilitation phase. So, time frame for management of a child with complicated severe acute malnutrition. So, there are 10 steps you need to take, and then they've given you the duration on when you need to focus on these steps. So, on day 1 to 2, the first three things you need to ensure you monitor are: you start with hypoglycemia, hypothermia, dehydration. These are the first three, followed by electrolytes and management of infection if present. Then for micronutrient replacement, you need to ensure when you're replacing your micronutrient, you do not give any iron from day 1 to day 7. You only start replacing with iron after week 2. Then initiate feeding. Usually depends on how the patient is progressing. So usually between 3 to 7 days or 2 a week, you should have started feeds. Then catch-up feeding is usually starting from day 3 all the way going to week 6 and so on. Then sensory stimulation starts at day 3 and prepare for follow-up. That's after week 2. So that's all about severe acute malnutrition. There will be another video that will be made on the management of severe acute malnutrition, in which all these 10 steps will be discussed in detail. Thank you.